Good morning, bonjour, buenos dias, guten morgen. A warm welcome to this presentation about functional abdominal pain in children. In the next 30 minutes or so, I'd like to tell you everything what is important with regards to children with abdominal pain. Why is it such an important problem? Because as you probably know, there's a high prevalence, there's a high cost, there's a lot of school absence, and there is lower quality of life in these children. And not unimportantly, some of these children have anxiety or are even depressed. Let me introduce you a general girl which you probably face at your outpatient clinic. She's 14 years of age, otherwise healthy, and she has pain around the umbilicum. And the pain waxes and weans, and if I ask her what kind of pain it is, she tells me it's crampy. Her defecation in this case is absolutely normal. She passes daily normal stool with a normal consistency. The pain is not related to meals, and she tried absolutely everything together with her parents to solve the pain. And not unimportantly, she misses schools. Almost 1 or 2 days per week. So this is the typical case of a girl or a boy who presents at an outpatient clinic at the general practitioner, but also at the general pediatrician wherever in Europe, or even the United States, or even at the other continents, because the children are generally similar. How do we make the diagnosis? Well, we use the so-called Rome criteria. And Rome, as you know, was not built on one day, but in 1999, pediatricians got involved and started to think about criteria how to define functional abdominal pain or irritable bowel syndrome in children. And during the years, we made some efforts and progress in recognizing children with these kind of disorders. So in 2016, a publication was published in Gastroenterology discussing the different functional abdominal pain disorders. And currently, we are rewriting these criteria, and we will not mention functional gastrointestinal disorder anymore, but we will talk about disorders of gut-brain interaction, stating the very important connection between the brain and the gut. So nowadays we recognize different types of functional gastrointestinal disorders, functional dyspepsia, in which children present with upper abdominal pain, irritable bowel syndrome. In those children, abdominal pain can be everywhere, but it's related to defecation, either constipation or diarrhea. We also recognize functional abdominal pain not otherwise specified. It's almost similar as irritable bowel syndrome, but it differentiates the two of them because in functional abdominal pain not otherwise specified, defecation is not a problem. And in rare cases, there is a relationship between migraine and abdominal pain, which is nowadays called as abdominal migraine. This is the world map of functional abdominal pain. And as you can appreciate, the percentage of children who fulfill these criteria are similar all over the world. And this, until now, is difficult to understand because, as you can appreciate as well, that in, for instance, a country as Sri Lanka, where the temperature is really high, there's a tropical situation over there. In some areas, there was war in the past. They have differences in diets and differences in culture. But still, if you look at the world map, the prevalence of these different functional abdominal pain disorders is the same as in countries like United States, but also in countries in Europe. How do we recognize these children? Do they only have abdominal pain? Well, this slide shows you that many of these children have more pain sites apart from abdominal pain. And this is always related to more difficulties in treatment. And as you can appreciate from this slide, headaches are involved, chest pain, muscle soreness, lower back pain, and sometimes joint pain. And also, if you have more locations where the children address pain, then more anxiety, more depression, and a lower quality of life is reported by these children. So in summary, the more pain sites these children with abdominal pain have, the more difficult it is to treat these children properly. And another very important symptom is nausea, and we really have to discuss this with the patient and her or his parents, because sometimes we don't ask for it, but we also know that those children who have abdominal pain and nausea, again, are more difficult to treat. What are the risk factors to have abdominal pain as a child? Again, this slide shows you the different risk factors, and for me it's always striking that we as doctors hardly talk about sexual abuse or physical abuse, although we do know that these different topics are related to abdominal pain. So I insist, I hope that you understand that you have to ask these questions to the patient and to the parents, because we do know how important it is, although it's of course difficult to ask the questions. Okay, let's meet the patient and his parents in your outpatient clinic. What do we do? Well, first we have to explain the mechanisms underlying abdominal pain. And as you can see from this slide as well, there are many different factors involved in the development of abdominal pain. Of course, there are early life events which might be related to abdominal pain, but also, as I already discussed, we have to ask in the medical history for physical abuse or sexual abuse. New in the relationship between the development of abdominal pain and new factors is the so-called microbiome. There are now scientific reports who discuss the existence of the microbiome, which is different in children with abdominal pain compared to healthy controls. Although I have to admit that more research is needed before we can truly say what the relationship is between the microbiome and the development of abdominal pain. The most important factor involved in abdominal pain in children is hypersensitivity, which means that these children have an earlier feeling of pain in the bowel compared to children who are healthy. So we have to discuss this hypersensitivity in these children. So the mother comes in with the patient, with her child. You can see it from this slide. And what do you think is important for the mother when she enters a doctor's office? Well, she of course hopes that he will do something. He will use blood, or he will use radiological investigations. She of course hopes that he will find it. But the child has a different agenda, because he or she thinks, what am I doing here? I hope they don't test. I don't they do some blood drawing. And the doctor, how does he behave before the patient enters with a functional gastrointestinal disorder? Well, if he's in a rush, he knows that he will do wrong. If he thinks in a different way about a differential diagnosis and only thinking of very rare conditions, he makes a mistake. And of course, he thinks about H. pylori, which is again a very difficult topic for doctors and the relationship with abdominal pain. How should a doctor behave? Well, he would think by himself, I cannot rush this. The patient needs attention. I need time to explain what's going on. And I try to explain and express that the pain is truly real. And and that the patient doesn't make something up. And I have to think about what's the next step. Would it be a non-pharmacological treatment in this child? So now we turn and switch to the diagnostic workup, because we have to differentiate between organic and functional gastrointestinal disorders. First, of course, the medical history, which is very important, and as shown on this slide, red flags are weight loss, failure to thrive, severe vomiting, blood loss, and during a physical examination you might come across oral ulcers or perianal fissures, or even arthritis or hepatosplenomegaly. We used to use the symptom of pain during the night as very important, but recent research has shown that this doesn't differentiate between functional and organic disorders of abdominal pain. The main factor which should be remembered from this slide is that if you have no alarm symptoms, we do know that more than 90% of these children have a functional cause of their abdominal pain. The differential diagnosis is of course long, but again I have to state that in more than 80% of all children, no organic cause can be found for abdominal pain. And this is a typical statement in the Rome 4 criteria. After appropriate evaluation, the symptoms cannot be fully explained by another medical condition. This is a difficult sentence, because what should the doctor do? Well, I show you in the next slides what you can do. Because again, if you look at alarm symptoms, so you just do the medical history, then we do know that chronic diarrhea, GI blood loss, weight loss, recurrent vomiting, perianal complications, but also impaired growth are truly related to an organic cause of the abdominal pain complaints. Of course, we have to look for another common disorder, especially in Europe, and that's of course celiac disease, because we do know that celiac disease is much more commonly found in children who present with abdominal pain. So please look for celiac disease. In a very nice paper from a few years ago, it was tested which clinical evaluation and blood parameters were necessary in combination with fecal examination to make a difference between functional or an organic cause for the abdominal complaints. And as this slide shows you, you only need limited testing to make the differentiation. Fecal calprotectin, look for celiac disease, ESR and hemoglobin are in combination with more than one alarm symptom has a sensitivity of 92% to find an organic cause for abdominal pain. So again, this is a little summary. You can do what you like with it, but this is how we do it in our academic center. We test for celiac disease. We do hardly any testing for on the fetus except for calprotectin, and we find radiological examinations not helpful in the far majority of cases. So then I make this little drawing for the patient. If the patient presents with abdominal pain more than 2 months, you do the medical history and physical examination. If there are no alarm symptoms, I do have the panel I just showed you, calprotectin, celiac disease, and if this is completely normal, then I'm almost sure that it's functional gastrointestinal disorders as listed below according to the Rome 4 classification. Irritable bowel syndrome, functional abdominal pain not otherwise specified, functional dyspepsia, and abdominal migraine or abdominal migraine. So the next 2 slides, I only show you which algorithm you might use to treat these children. For me, it's very important that we make a differentiation between children with irritable bowel syndrome who present with abdominal pain accompanied by either constipation or diarrhea, and these children should be, in many cases, treated differently than children with functional abdominal pain not otherwise specified, where defecation is not involved. So you can imagine that you treat the child with irritable bowel syndrome and constipation with a laxative, whereas children with functional abdominal pain not otherwise specified should never be treated with a laxative. If you really want to read more, then you can look at this paper. So now, this is specifically for the general practitioner or for the general pediatrician, how to treat the children who present with functional abdominal pain. So first of all, we have to reassure. It's not a very difficult disease, but it's of course frustrating because these children complain and miss school. But it's also a positive diagnosis. We know what it is. It's very common, and this must be discussed with the parents. As I told you before, it's hypersensitivity is the main factor involved in all children with abdominal pain disorders, and if possible, go back to school as soon as possible. And all this information should be given in the first hour you see the patient and her parents. It's called the golden hour, golden half hour in children with abdominal pain. A beautiful paper in JAMA Pediatrics a few years ago. Again, you discuss with the parents and the child the expectations. You offer a positive diagnosis. You provide education about for instance, irritable bowel syndrome with constipation. And if necessary, you ask the help of a dietitian or a psychological intervention or sometimes physical activity. And you have to stay connected, not only for one day, but for weeks and even for months, because these patients deserve it and need it, because otherwise they're helpless and they need your attention and advice for a very long period. And of course, you offer them an optimistic appraisal, because we do know that within 1 year, 80% of the children will be cured from their abdominal pain complaints. Okay, let's talk about different therapies now. So again, the first the first step in treatment is discuss and reassure. You discuss the prevalence. It's very common all over the world. It has a benign clinical course in 80% of the children. Sometimes it's intermittent, but it often impacts quality of life. And I very much like this study as presented by Lynn Walker some years ago. And this is what mothers should do if they have a child with abdominal pain. And this study studied the influence of attention. And it was a water drinking test was used to give information to the parents. So 1/3 of the parents of patients with abdominal pain and children who were healthy were asked to distract their patients during a certain test. They were able to read books or tell them stories or play games. And 1/3 of the parents was advised to do nothing. Just sit there and wait till the test finished. And 1/3 of the parents was asked during the test to ask after every intervention to ask, did you feel pain? Are you already nauseated? Do you think you will make the next day? And of course, you do know what the result of this study is, showing from this slide that those parents who distracted their patients and who distracted even the healthy child had no or almost no pain at all. Whereas those children who received attention to the pain, they indeed complained of much and significantly more pain than those children who were distracted. The most surprising data from this study was, however, after the study, they asked the mothers how they felt about this study. And they said they felt very inappropriate because they thought their children were in pain, but they were not able to discuss it. So one of the most critical advices you should give after the first visit at your office, that mothers can't discuss pain for the next 4 weeks. The patient can always come to the mother if they are in pain, but the mother can never ask the question, are you in pain? Do you have pain? Do you think you can go to school? You don't ask a thing. and it helps. What about food? There's a lot of rumor about food and the development of abdominal pain, because we do know that, for instance, a beautiful study from Switzerland, that 16% of children and adolescents avoid foods, and half of them without any medical advice. And the food avoidance in these Swiss children were because of lifestyle habits and true intolerances with possible consequences, such as micronutrient deficiency if they were not properly monitored. And 50% of these affected Swiss children avoided foods without guidance by any professional, which is, to my opinion, also dangerous. So yes, there might be a relation between the food intake and abdominal pain, but we have to make a diagnosis, and if so, the children should be guided by a professional dietitian. What about the interventions which were really evaluated, if they were effective in these children? Well, there's a recent paper with a disappointing number of patients who were included in the different studies, where they investigated the efficacy of fibers, FODMAP, fructans, and serum-derived bovine immunoglobulin. No studies were found on treatment with additional fluid intake or a histamine-free diet. A little bit about the FODMAP diet, because to my opinion, again, this is important. People look at the internet, so they know about the existence of a FODMAP diet. And we, as pediatric gastroenterologists, are often asked for these diets. This is the acronym: fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. And studies from Australia have shown that these carbohydrates increase the production of gas and sometimes accelerate transit time, which results in diarrhea, abdominal distension, and bloating. And this is the study from gastroenterology in Australia, where you indeed see that if you have a low FODMAP diet, that the gas production in the breath hydrogen test is significantly lower compared to those Australians who had their own diet. And these Australian doctors went on together with the dietitians and showed indeed that in IBS there was a significant decrease in bloating, abdominal pain, and the passage of wind in their patients. But this is in adults with IBS. What about children? Well, to be honest, there are not very good studies. This is a study from the United States, where they did a very short period of a low FODMAP diet in children with irritable bowel syndrome. They showed some efficacy, but we need longer studies to really see if this very difficult diet is helpful in children, because we can't forget that a low FODMAP diet is extremely difficult to fulfill, not only for the child, but also for the parents who do the cooking. And more importantly, recent studies have shown that you again need a specific dietitian who can guide you through this very, very difficult period. So if you don't have the symptoms of bloating, diarrhea, and increased flatulence, I truly ask myself if a low FODMAP diet is worthwhile to test in these children. What about probiotics? Also a very difficult topic, always asked at our outpatient clinics. Are probiotics helpful in children with whatever disorder, and in this case abdominal pain? Well, this last very well-performed Cochrane review can't give you any evidence that of a specific probiotic strain which is really, really helpful in these children. Again, it's not harmful, but the evidence is really, really thin. So what can we say based on the scientific evidence these days? You can try fibers because they lack in the majority of children side effects, but if they are truly effective, I question mark this. So I switch gears now to the next treatment of children with abdominal pain, and it's the non-pharmacological treatment of abdominal pain, behavioral therapy or hypnotherapy. And again, This is a very nice systematic review, which was performed only last year, evaluating all the different non-pharmacological treatments and behavioral therapies in these children. I'd like to highlight two examples. This is a cognitive behavior therapy performed in the United States, not only including children, but also parents. They did relaxation training, they worked with the parents, and they did cognitive restructuring. And indeed, it was in their hands, really effective. So those children who received cognitive behavior therapy were better off than those children who didn't receive this specific treatment. The advantage of this American approach was that you only need a few sessions to improve. Hypnotherapy, also a nice topic to discuss. What is hypnotherapy? Well, this is based on the studies Peter Warwell, a gastroenterologist living in Manchester in the UK, developed already in the 80s of the last century. It's 6 sessions. It includes general relaxation, including breathing exercises. It controls abdominal pain and gut functioning, and it gives ego-strengthening suggestions. And more importantly, the child is always in control. And again, we did these studies already 20 years ago, and this slide shows you in blue, that's myself, the pediatric gastroenterologist, who was able to use painkillers, laxatives, diets, any other drug I thought would be helpful for these children. And in pink shows you the line of the hypnotherapist who was working outside of the hospital. And you can clearly see from this slide that the hypnotherapist, without any other help of any drug or diet, was significantly better with respect to pain intensity and pain frequency compared to the experienced pediatric gastroenterologist. And in the next slides, you also see, and to my surprise, the efficacy, the effects of hypnotherapy sustained not only after 1 year, but even after 5 years. We went on doing these studies, and at the same time, Miranda van Tilburg, a psychologist in the United States, used CDs on which she put our hypnotherapy exercises. And she showed that even without an hypnotherapist, an individual hypnotherapist, this therapy was effective. And therefore, we executed a very large trial, including almost 300 children with different types of IBS and functional abdominal pain. And the major thing about the study was that the children who were included had pain for at least 2 years. And a high number of these children had frequent school absenteeism. So we compared in this study our own old results, so the individual hypnotherapy, and compared this with the exercises which we now put on a CD. So from their houses, they could do the exercises themselves. And again, to our surprise, both treatments, either by the therapist or by the CD, was very effective in more than half of the children. And more importantly, both parents and the children were really happy with the therapy, and they even defined their success as adequate relief in almost 80% of all children. So a very good result. And not only was this successful with respect to abdominal pain, but also if you look at the decrease in anxiety, depression, quality of life, and pain beliefs. More importantly, there was no difference between those children who had the criteria fulfilling irritable bowel syndrome, either constipation or diarrhea, and those children who fulfilled the criteria for functional abdominal pain not otherwise specified. Also, very importantly, we also looked at the efficacy of the different therapists involved in the different hospitals who were involved in our study. But again, no difference between the therapists in efficacy using hypnotherapy for children with abdominal pain. Again, we did a long-term follow-up on these children, and for both groups, we showed the same results as our first study, which showed that more than 60% of the children were still without any abdominal pain complaint after 5 years. Now you can use hypnotherapy in your own country because we translated our exercises in Dutch. Most of you don't speak Dutch, but there's an English website and there's a Spanish website again as well, where we translated all our exercises in these languages. And currently we are busy to make the same links for Germany, Hungary, Sweden, Belgium, and France. What about medication? Again, very disappointingly, only approximately 1,200 children with fulfilling the Rome 4 criteria for abdominal pain were evaluated in randomized controlled trials. Some of them I will highlight, the antispasmodics, because they are used frequently. There's hardly any evidence that they work. This is a very small study which showed no adverse effect, but was only for 2 weeks, which hopefully you understand from this little presentation that most of these symptoms are there for at least 2 months, but in some of these children for many years. So a poor study, so we don't have clear data yet what the efficacy is of spasmolytics in these children. Another drug which is used mainly in the United States is an antidepressive medication. And in this case it's amitriptyline, very well studied in the United States. And as you can see from this slide, and very surprisingly, the placebo effect in this study was uncommonly high. More than 50% of the children were cured with a placebo, and this was exactly the same as those children who were treated with the antidepressant. However, a recent study in adults with IBS showed again that these kind of drugs are very helpful in adults with severe abdominal pain. So to my opinion, we should use these drugs a little bit more in Europe and follow our American colleagues. Okay, then what's coming up? Well, I already discussed with you the microbiome, and studies from the United States have shown that there is indeed a difference in the microbiome between children with abdominal pain and healthy controls. And this is a study already published in Gastroenterology. And now many doctors are working on fecal transplants, on different probiotic strains to influence the microbiome and thereby hopefully treat these children in a better way than we used to do. But this is future work. So almost at the end of the presentation, what about placebo, which is so interesting and intriguing in children with abdominal pain? And this study, also from a few years ago, showed that in the studies which are now available in the literature, if you look at all these studies together, more than 40% of the children get better with the use of a placebo. So what is the meaning of this? Are these children crazy? Not at all. But it shows you the strength between the brain and the gut. So if you discuss this properly with your patients and the parents, then we might need placebo also in the future of these children, or we have to use different language in which we discuss the working mechanism of a drug, in which we say, oh, you are so lucky because you will receive this drug from me, and we know that it helps in more than 90% of the cases. Only this little sentence might help your patients in getting better of abdominal pain because of the results of these studies. So, at the end of the day, wherever you live in Europe, I try to discuss with you how important it is to recognize and better define your patient with abdominal pain. Discuss with them that we know what it is, that irritable bowel syndrome is not a crazy saying, but a true, very common symptom and entity in children with abdominal pain. Tell them that that many of these children have impaired quality of life and that we do know that the pain is completely real. And try to make a positive and patient-physician good relationship. Food, until now, plays only a minor role. But if you discuss with the patient that you indeed will change the diet a little bit, ask the help of a dietitian. These people can't do it by themselves. The role of FODMAP, a very severe and strict diet, you can never do without a specialized dietitian. And again, we need larger trials to really evaluate if this is a good treatment for children with abdominal pain. I hopefully convince you that non-pharmacological treatments as cognitive behavior therapy and hypnotherapy are very well studied and are helpful in the majority of children with abdominal pain. And we do now have certain links in different countries which can be used to treat the child by themselves at home in specific countries. And the current treatment of the current use of pharmacological treatment is has very low evidence. But again, we have to wait for the results of the randomized controlled trials evaluating spasmolytics, and there is good evidence now that antidepressants like amitriptyline might be helpful in specific cases of abdominal pain. The future? Fecal transplants? I don't know. We have to wait and see. Placebo? I wished that we could use them, but until now there are restrictions in probably every European country to use a placebo. I thank you very much for your attention. Hopefully this was helpful for you. We as doctors, as healthcare professionals, we do know how important it is to recognize the child with abdominal pain and help them as good as we can. Thank you very much.